3, 2, 1.
A warm welcome to today's talk. I'll be talking about mitral stenosis. Okay, what is mitral stenosis? Stenosis means narrow. So normal valve size, the valve size of the mitral valve is about 5 to 6 centimeters square. Here in mitral stenosis, this becomes narrow. Okay. What are all the causes of mitral stenosis? Remember, 99.9% of mitral stenosis is rheumatic in origin. So you'll have to take a detailed history to find out whether the patient has had previous rheumatic fever. So 99.9% it is only rheumatic. Very rarely it can be congenital. Lutembaker's is one condition where you have ASD with acquired mitral stenosis. Drugs like methotrexate can cause mitral stenosis and also amyloidosis. But remember, it's most of the time only rheumatic. Okay. What are the symptoms with which they can present? I'll just tell you about the pathobiology and the hemodynamic changes that are taking place in the mitral stenosis so that you can understand how it presents. I told you the normal valve size is about 5 to 6 centimeters square. When it gets reduced to 2 centimeters square, it becomes moderate. Moderate because the patient will start developing symptoms. What are the symptoms? The earliest symptom is shortness of breath on exertion, dyspnea on exertion. What happens when the patient exerts? There will be tachycardia. Okay. This is a stenotic mitral valve. Okay. The blood, normally the blood enters from the left atrium to the left ventricle, goes out to the aorta, then comes back pulmonary artery to the right atrium, right ventricle, and goes to the lung. Okay, through the pulmonary artery. Okay, here there is a stenotic mitral valve. Okay, what happens when the patient exerts? There will be tachycardia. So what happens is that during tachycardia, the diastole is reduced, not the systole. So the time allowed for the left ventricular filling is going to be reduced. So there will be back pressure. So these will back up, the left atrium will back up into the lung. So there will be pulmonary congestion and the patient will start developing dyspnea on exertion. That's the commonest, earliest symptom. Okay. When it gets reduced to 1 centimeter square, the mitral valve size gets reduced to 1 centimeter square, it becomes critical. Critical because at that point of time, the left atrial pressure goes up to 25 millimeter mercury, more than 25 millimeter mercury. So at that point there will be a lot of back pressure and the chances of patient developing acute pulmonary edema is very high. That is why it is critical. Secondly, if you take the normal cardiac cycle, what will happen? The left atrium opens, blood enters into the ventricle directly, and then you will have atrial systole, the atrial kick. The atria compresses and pushes whatever blood that is left into the left ventricle. Then the systole commences, the left ventricle contracts, the mitral valve closes, and the blood is pushed out of the aorta. What happens when the blood, when the size of the mitral valve is reduced to 1 centimeter square is that the atrioventricular valve, the mitral valve opens, but because the valve is so narrow, hardly any blood will enter into the ventricle. So left ventricular filling will be solely dependent on the atrial systole or the atrial contraction, atrial kick for the blood to enter into the left ventricle. So that is another reason why the chances of patient developing acute pulmonary edema is very high when there is a critical stenosis. So if it continues to maintain above 25 millimeter, I told you there will be backing off of blood into the lung. Certain changes will take place in the pulmonary vasculature. Patient develop pulmonary hypertension. Once the patient develops pulmonary hypertension, what happens to the right ventricle? Right ventricle empties blood into the lung, correct? So the right ventricle will come under strain because of pulmonary hypertension. So in order to cope up with the increased pressure, there will be right ventricular hypertrophy. Okay, the right ventricle will hypertrophy in order to pump blood into the lungs. After some time, even the hypertrophied right ventricle may not be able to cope with the pressure, so it dilates. So once it dilates, the tricuspid valve will not be able to come together. So because of the dilatation, so you will have a functional TR, functional tricuspid regurgitation. This is the hemodynamics. Okay. How does it manifest clinically? Symptom wise, I told you the patient has shortness of breath on exertion. I told you how. There is right ventricular hypertrophy. So there is more muscle mass, but the left ventricular output is reduced because the left ventricular filling is reduced. So the coronaries will be compromised. More demand, less supply. So you'll have chest pain, anginal type of chest pain you can have. You will have palpitation. What happens is that I told you there is narrowing of the mitral valve. See, the left atrium will come under pressure. I told you it will go about 25 millimeter. See, once it goes up, see, this is not, used to that sort of a pressure. So they will dilate, the left atrium will dilate. Once it dilates, the chances of patient developing atrial fibrillation is very high. So you'll have palpitation. Okay. Will you have syncope? Yes, because the left ventricular filling is reduced, the left ventricular output is reduced. So if the patient goes in for atrial fibrillation or if the patient exerts himself, the output is even more reduced. The cerebral perfusion is going to be compromised and the patient will develop syncope. Pedal edema, yes, because of the right heart failure, we will have pedal edema, abdominal distension, elevated JVP. These are all the symptoms you will have in mitral stenosis. So all the 5 cardinal symptoms of cardiovascular system like chest pain, dyspnea, palpitation, syncope and pedal edema are present. Apart from it, because the decreased systemic circulation, because the decreased cardiac output, there can be decreased renal perfusion, so decreased urination and mitral phases, tiredness, all these are other features that will be present in patient with mitral stenosis. What are the signs that will be present in mitral stenosis? Starting from pulse. Because the left ventricular output is reduced, you will have a small volume pulse. Most of the time, you will have an irregular pulse because the patient will be in atrial fibrillation. Okay, so you will have a small volume, irregular pulse. The BP is going to be on the lower side. What will happen to the JVP? You will have a prominent V wave in the JVP. See, because the JVP represents the right heart. Okay, A corresponds to atrial systole. The right ventricle is hypertrophied and non-compliant because of the pulmonary hypertension. So, during atrial systole, you will have a prominent A wave. Okay, that will be there. Later on, when the patient develops pulmonary, TR, tricuspid regurgitation at the later stage, you can also have a prominent V. So, A and V can be there. But once the patient goes in for atrial fibrillation, the contraction will not be strong enough to cause a prominent A wave because the fibrillating atria will not contract strongly. Okay, that is about the JVP. Precordium, the apex will generally be in the 5th intercostal space. It may be shifted laterally because of the right ventricular hypertrophy. We will have a tapping type of apex beat. The tapping apex beat in mitral stenosis is because of the loud first heart sound and also the right ventricle pushes the left ventricle laterally. So, we will have a tapping apex beat, 5th intercostal space, lateral to the midclavicular line. You can have a palpable P2 because of the pulmonary hypertension. P2 can be palpable. You can have a parasternal heave. The parasternal heave can either be because of left atrial enlargement or because of right ventricular hypertrophy. Okay. How to differentiate a parasternal heave because of left atrial enlargement and a parasternal heave because of right ventricular hypertrophy? If it occurs in diastole, it is left atrial. If it is systolic parasternal heave, it is right ventricular. Okay. On auscultation, you will have a loud first heart sound if the valves are pliable. Okay, you may have an opening snap followed by mid-diastolic murmur and a pre-systolic accentuation. The murmur being from the mitral valve is best heard in the apex. So you will have a loud S1, opening snap, MDM, pre-systolic accentuation. Remember, this pre-systolic accentuation will be lost if the patient goes in for atrial fibrillation because that is the atrial kick is the one which is contributing to the pre-systolic accentuation. So, once the patient develops AF, there are certain findings that will be missing. A prominent A wave in the JVP will be missing, okay, and then you'll have the pre-systolic accentuation will also be missing, and the loud first heart sound will become variable in intensity once the patient develops atrial fibrillation because of the varying RR interval. Okay. So these are the findings. So summarizing again, you'll have pulse, you'll have small volume pulse, atrial fibrillation, BP will be low, JVP will have a prominent A wave. The A wave will be absent if the patient goes in for atrial fibrillation. You may have a prominent V if the patient has a functional TR. Okay, you'll have a parasternal heave. Then you'll have you'll have a tapping apex beat, palpable P2, parasternal heave, which can be either systolic or diastolic. You'll have a murmur, loud first start sound, MDM, pre-systolic accentuation. Okay. Remember, the S2-OS gap will tell you the severity of mitral stenosis. The narrower the S2-OS gap, the more severe the mitral stenosis. So what are all the complications of mitral stenosis? One, obviously you can have pulmonary edema because of the backing of blood into the lung, atrial fibrillation, which can lead to stroke because stasis of blood can lead to clotting, and you can have stroke secondary to atrial fibrillation. There's one thing called the left atrium may enlarge and may compress on the esophagus or the recurrent laryngeal nerve or the trachea. That's called Ortner syndrome, right heart failure, and finally you can have a functional TR. All these are complications of mitral stenosis. Now, how to treat mitral stenosis? First, you'll have to treat the failure, okay, with anti-failure measures. You have to give diuretics, beta blockers, okay. Atrial fibrillation, again, digoxin will be useful, and again beta blockers are the cornerstone in treating atrial fibrillation. Infective endocarditis prophylaxis should be given if the patient is undergoing a procedure, and if it is an isolated mitral stenosis and if the valves are pliable, you can do a valvotomy. You can dilate the mitral valve orifice by doing a valvotomy. But remember, if the valves are calcified and if the patient is having associated MR, you have to do a valve replacement. Okay, this is about the treatment. This pretty much summarizes what you need to know about mitral stenosis. Thank you.